All right, let's dive right into this high-yield review of prostate cancer. If you're studying for your BCOP or just want a quick and dirty clinical update, you're in the right place. We're going to hit all of the must-know guidelines and landmark trials. Okay, let's kick things off with a case that you'll absolutely see in practice. A 72-year-old guy, PSA is climbing on Leuprolide, and boom, scans show Mets. The question is, which regimen gives him the best shot at survival? Don't worry, we're not going to answer it just yet. Tuck that question away because by the end of this, the answer will be crystal clear. All right, section 1. Before we can even talk about treatment, we've got to get the foundation right. We're talking diagnosis, genetics, and yeah, even a little bit on that whole screening debate. First things first, a really key concept. Throw the term androgen independent out the window. It's old news. Today, we call it castration-resistant prostate cancer, or CRPC. And why does that matter? Because it reminds us that the androgen receptor is still the bad guy. It's still driving this cancer. That's literally the whole reason our treatments keep hammering away at that pathway. So let's get into the genetics, because this is a game changer. We're talking about key markers like HRR mutations, your BRCA1 and 2, and MSI high status. Now, here's the high yield point. NCCN says we have to test for these, both germline and somatic, in pretty much all our high-risk or metastatic patients. And this isn't just for fun facts. These results directly dictate which targeted drugs we can use later on. It's moved from nice to know to need to know. All right, PSA screening. Look, we could spend an entire day debating this, right? But for your exam, here's the deal. It's super controversial. You're constantly weighing the benefit of catching a deadly cancer early against the harm of overdiagnosing a slow-growing one. What you really need to know is that while the guidelines from different groups might have slightly different cutoffs, they all land on the same conclusion. It's all about shared decision-making, period.
Okay, moving on. Let's talk about localized disease. This is where things get interesting because the big question is, do we watch or do we act?
And this chart really lays it all out. The key thing to see here is that we don't just treat based on stage. It's all about risk stratification. You can see how the plan completely changes if someone is very low risk versus intermediate risk. It's not one size fits all. It's a careful calculation of their cancer's aggressiveness and their overall health. Okay, let's clear up a common point of confusion: observation versus active surveillance. They sound similar, but they are worlds apart. Think of it this way. Observation is for comfort care. We're not trying to cure it, we're just managing symptoms for someone with a limited life expectancy. Active surveillance, on the other hand, is curative intent. We're watching that cancer like a hawk, with frequent tests and biopsies, ready to jump in with definitive treatment the second it looks like it's getting serious. The intent behind it changes everything.
All right, buckle up. We're at a huge turning point in the disease now: metastatic castrate-sensitive prostate cancer, or MCSPC. Honestly, the standard of care here has been completely flipped on its head over the past few years. And here's the proof. Look at this. The days of just giving ADT alone for newly metastatic disease are pretty much over. That is not the standard of care anymore. The NCCN guidelines are screaming it from the rooftops. We have to intensify treatment from day one. So what does intensification mean? We're talking about hitting it hard up front with either doublet or triplet therapy. Doublet is your ADT plus a heavy hitter like abiraterone or enzalutamide. But for the sicker patients with high volume disease, we go for the triplet. Remember these trial names? Arisons and Peace One. They proved that ADT plus docetaxel plus a novel hormone agent gives a massive survival benefit. It's a huge deal.
Okay, now for the main event: castration-resistant prostate cancer. This is the big challenge, right? The cancer has outsmarted our initial therapy. Getting the sequencing of drugs right in this space is probably one of the most tested concepts, so let's really dig in. So, when a patient becomes castration-resistant, the first question we have to ask is, where's the cancer? This creates two totally different paths. There's non-metastatic, or M0, where we can't see it on scans yet. Our goal there is simple: keep it that way for as long as possible. Then there's metastatic, M1, where we can see it. And now our goal shifts to extending life and maintaining quality of life. Two different problems, two different playbooks. For that non-metastatic group, M0 CRPC, here's the high-yield info. The trigger for treatment is a PSA doubling time that's fast. We're talking 10 months or less. When that happens, you have three go-to drugs: apalutamide, enzalutamide, and darolutamide. Know the drugs and know their trials. Spartan, Prosper, and Aramis. They all did the same thing. They crushed their primary endpoint of metastasis-free survival. And now we even have data showing they improve overall survival too.
Okay, back to the metastatic setting. And this is a super common scenario. Your patient has already had docetaxel, they've already had a drug like abiraterone or enzalutamide. Now their cancer is growing again. What do you do? This is a tough spot.
Thankfully, the CARD trial gave us a definitive answer. They took patients in this exact situation and randomized them to either cabazitaxel chemo or switching to the other hormone pill. And wow, it wasn't even a fair fight. Cabazitaxel blew the other arm out of the water, basically doubling progression-free survival and improving overall survival. So the takeaway is huge. In this setting, don't just flip-flop hormonal agents. Go to cabazitaxel.
All right, let's wrap up with the newest stuff. Targeted agents and the critical supportive care we, as pharmacists, provide.
Remember that genetic testing we talked about at the beginning? Well, here's the payoff. If your patient has one of those HRR mutations, like BRCA, bam, you can use a PARP inhibitor. And we've got multiple trials, Profound, Triton, Propel backing this up. Then there's this other really cool approach, PSMA-targeted therapy. If their tumor lights up on a PSMA scan, we can use lutetium-177, which is like a smart bomb that delivers radiation right to the cancer cells. The VISION trial proved it works. And this is what it looks like in the clinic. This NCCN pathway for patients with those HRR mutations shows you exactly what to do. It helps you decide, based on what treatments they've had before, whether to use a PARP inhibitor by itself or maybe combine it with something else. It's truly personalized medicine in action. And finally, let's talk about where we, as pharmacists, really shine: supportive care. This stuff is our bread and butter. For bone mets, we're on top of bone-modifying agents like denosumab and zoledronic acid. For patients on long-term ADT, we're the ones watching for metabolic issues, cardiovascular risks, diabetes. And, of course, if a patient is on denosumab, who's making sure they're taking their calcium and vitamin D? We are. This is absolutely crucial. You know, this quote really nails it. We have so many weapons against this disease now. The real trick, the art of it all, is figuring out the perfect sequence to use them in. Which leads me to a final, big picture question for you to think about. With a dozen or so approved drugs, is it possible that the sequencing, the order in which we use these drugs, is now the single most important factor that decides how well a patient does? It's something to chew on. And hey, after all this, I bet you know exactly how to help that patient we talked about at the beginning. Thanks so much for tuning in.